good afternoon, good evening, wherever you are in Waterloo, Ontario, Canada, or elsewhere in the world, welcome to you. My name is Ian Rowlands, and I'm the Associate Vice President International at the University of Waterloo, and I'm also a professor in the Faculty of Environment at Waterloo. I'm honored to be moderating this session today on international perspectives, and I'm so pleased that I'm joined by three such knowledgeable and experienced panelists. I'm also delighted that you have joined us for the session today. And let me share with you how we anticipate the next 60 minutes will unfold. After I briefly introduce our three panelists, I'll invite each of them in turn to give some opening remarks. After all three have given their remarks, we'll turn to your questions. Questions that have been submitted previously, and questions that you will want to submit in real time through chat on this virtual platform. As things come to your mind during the next half hour, please feel free to put them in the chat, and the team here will be working to channel them through to our panelists today. We'll aim to wrap up by 2:30 local time at the latest, and then we'll move to a short break in the conference. With that agenda for our next hour, let me now turn to our panelists and welcome them, as well as briefly introduce them at this point. And let me note that I underline that word brief. My introductions of our panelists will be very brief to give them more time to share their experiences and perspectives. But beyond the name, title, and organization that I share, I encourage you to go to the website to find out more about their backgrounds by reading their full biographies there. So our three panelists today, first we'll have Boye Eliassen, and Boye is Director of Health at the Copenhagen Institute for Futures Studies. And second, we'll have Nigel Hughes. Nigel is a Scientific Director at Janssen and Project Lead with the European Health Data and Evidence Network. And third, we'll have Jillian Oderkirk. And Jillian is a senior health economist in the health division of the Organization for Economic Cooperation and Development, the OECD, in Paris, France. I welcome all three panelists, and I'm hearing the clapping in the virtual world already. Very grateful for your presence today. So with that, let me invite each of you in turn to give some opening remarks. And first, Boye, I invite you to the virtual stage.
Thank you so much, and thank you for having me here. I've really looked forward to be a part of this nice hour, and I hope I can make justice to the time people want to spend with us here. I'm just trying to see if I can share the screen here. So I think my slides are up now. So yes, I'm Boye Eliassen from Copenhagen Institute for Future Studies. I'm originally from the Faroe Islands. I'm a proud Faroese living in the middle of nowhere with a climate that sometimes is a bit like parts of Canada, of course. So I will try to look into some of the things that we see that are really important for the future of health in this part. The Institute is 50 years old, so we have done some things going in our lifespan, so to say. And I think I did something wrong now, but you can still see me. I think I lost my slides in some way here.
We can see you, and you're right, the slides may just be off.
Yeah, now it comes.
Oh, there they are. Excellent.
There are. So what is very important here, and this is the luxury of being the future, is that we can push on what we want to have and not necessarily carry it out. But questions before answers are very, very important in order to build the future playing field. So in my opinion, and the way that we work, health is at a breaking point. We need a new paradigm. We cannot really realize the full potential of technology and concepts that we have going into what we really want to do. So, and if we only are looking for answers, we will find those solutions in brackets, so to say, inside the current paradigm, and that won't solve our issues. And the reason is very simple. We have a huge burning platform. We are getting older, but we are also increasing the disease burden in the person's life. So we get more life years, but also more disease burden. We have a huge focus on end-of-life solutions, and we have a huge focus on disease, not on health. We can take an example just looking at typical chronic diseases. We know that we should really look at coming earlier and earlier. So the left side on your screen on early intervention and early detection and prevention if we can. But our reimbursement systems are in most places so that we enter very late. So the impact of what we do is not as good as it should be, and the cost of what to do is much higher than it has to be. But what is it we are working for in reality? So best possible quality of life and well-being is our goal during the lifespan. So, and here comes the questions. Do we want to have the best possible health system so they can do the most advanced care or most advanced surgeries, most advanced treatment, or do we want to have the healthiest population? An example from Europe could be that Denmark definitely has one of the best hospital systems in the world and in Europe, while the longevity in Spain is higher, but the health system is not as good. So we should also think about what is it really we're trying to do with the health system and what is the outcome we're looking for. So we are entering into some totally new aspects where technology and concepts are taking us to. We are having a biological revolution that really started with the Human Genome Project some 20 years ago, but it's not just about the genomics, it's about all the things of new understanding of biology, which, for instance, has done that we could both have fast vaccines and follow the different changes in the COVID that we have had. There is the real-world data and real-world evidence that's coming in. How do we work with that? It also goes much outside just the normal clinical field. We are entering into some sort of evidence-based care for one, if we really want to work with precision medicine or personalized health. And we also need to move more towards what we call precision public health. So how do we align both the new biological knowledge, the social determinants of health, and different ways of getting equity really on the agenda by looking at people from where they are and not just where we want them to be. And then we probably need to figure out if we want to change to look from lifespan to actually health span. So how do we keep people as healthy as possible for as long as possible? So this is also very much about doing the right things right, but also really moving from feel good to do good. And we are reaching soon a point where a full genome scan in a clinical way will cost $100, but so does assembling a lot of other data for a person will also be around $100, where we can see different kinds of behavior and environmental impacts. And there you get a very big, if not complete, digital picture for $200, much cheaper than the CT scan. And that will change many ways on how we can work. But what does it require? It does require that we begin to think a lot about transparency, but also dignity, to get dignity into the equation here. So really having transparency, traceability, and accountability may be built with dignity in, so we can work with data and this knowledge in different ways. In a work we did a couple of years ago in the Nordics, we aligned on that we should have an aspiration where half of the budget should be focused towards prevention. Probably, but it's not just primary prevention, probably most of it on secondary prevention, but really seeing the health budget as an investment. So we have moved from being in the industrial societies, the knowledge society, so we should also move our way of investing to invest in people, so to keep people healthy for as long as possible in that way. And that also takes us to other principles. One of them is 1090. So most of all health things that we develop, they are focused towards the 10% richest in the world. So we need to change that in order not to also to get global equity, but also this 80-20 about really keeping most part of the population as healthy as possible, so we can really help much more to those who really need it, which normally are around 20% in a society. So how do we give them the best possible care? And then it also is very much about who do we protect and how. For human rights, we spent 200 years to to have individual protection from states, from organizations, from criminals. In the cyber world, we are a bit naked yet. We are always also talking about data protection, but in reality, we have to protect people. It's not the data we should protect. It's the persons that we should protect, and we need to figure out how that looks like in a cyber world. We can't use analog mindset to solve those issues. One thing that we have developed in order to work with that is what we call the humanome. So this is a thought experiment saying, okay, what if it's the person that is the data repository and the biobank? What if we give the person the right to use the portability of the data in different ways? Because if you look at these four buckets we have here with societal factors, biology, personal behavior, and environmental, micro and macro environmental factors, we have data on all of this already. The question here is, can we set it up in a way so it actually is beneficial for the individual person and for the society? And that's where I think the paradigm shift is coming in. But here, of course, we need data controls, we need data contracts, we need to work with interoperability, we need to have transparency, secondary use, consent in a new way that we maybe do not really know. But the data alone for the individual person is not really good if we can't use it in an aggregated pool as well. So that's why we also need to be working with what we call a sustainable health model, where we have a real-time more feedback loop between the individual and the system, where we can use data and make data usable for the individual person, and not just think about having health data so the system becomes more efficient in it. So in the end, I mean, this is very much about how can we create societal value while helping individual citizens as well. And here, our way of looking at this is saying health is the most important societal pillar. We need to move from protection of data to protection of people, from having a Fort Knox to beneficial use of data. So it's also helping people to use data and reuse it in a dignified way, to have a paradigm that shifts from an analog to a digital mindset. So the old privacy will never come back. So we need to invent a new one. Maybe to go from the lifespan to the health span. So the same money is used on the same person, but differently and for better impact and output for it. To move from a cost to an investment for persons. Really have a focus on equity and really help the many. And also to have a huge focus on equity for the quality of life in that way. And the last point here is that until maybe 180 years ago, we had death houses as hospitals. You came in with people, half of them died, half of them come out again. Nobody really know how and why, what happened. Then we got the modern hospitals with modern medicines, which is really sick houses. Now we need to invent health hubs. And that means that we need to do the right things and moving from feel good to do good. Thank you so much.
Boy, wonderful. Thank you very much for that presentation and those insights. And I think we'll be returning to many of those points, but delighted as well to turn to our second speaker now. And as a reminder, our second speaker is Nigel Hughes. So Nigel, I'd like to now invite you to the virtual stage.
Thank you very much indeed, Ian, and thanks to the organisers for the invitation to speak today and follow a really phenomenal presentation from Boya, which has set the scene very nicely, I think. So I'll just cover off a few points in my introductory remarks, as it were, cryptically maybe called not reinventing the world. Just to reinforce, I do work for Janssen, so I'm an employee of Janssen. I have stock in J&J, Johnson & Johnson, but I have these are all my own personal comments and don't represent my organisation. So I think just a few introductory aspects. First and foremost, it's inevitable, I suppose, that we mentioned COVID-19, but in some respects, more than 2 years now into this pandemic, I do like this cartoon in terms of, what led the digital transformation of your company. Was it your chief executive officer, your chief technology officer, or indeed COVID-19? And of course, dreadful that it has been in terms of a global pandemic, it also has acted as a kind of lens on some of the challenges that we face in public health, healthcare, utilization of data being at the right place at the right time to answer the right questions, which it hasn't been in terms of the pandemic. but also it's acted as an accelerator for a number of trends, one argues, particularly around data, particularly around collaboration, both technical and in terms of from a research perspective, as well as other digital trends like the adoption of, for instance, things like telemedicine or remote studies. All of these have been accelerated over the last couple of years in response to the pandemic, and I think one would hope that we can continue to reap the opportunities afforded by a pretty much global disaster going forward. I've taken up 4 points that are linked to the recent strategy documents in Canada. And one is around governance, and actually a large part, in some respects, from our previous presentation from Boyer, a large part of our challenge is not technical, it's not related to data, it is indeed related to governance. And there are very many models that I could present today, but for instance, simple ones like this Boston window around trust versus relevance, and increasingly, and particularly in a lot of programs that I work in, and particularly related to things like EDEN, European Health Data and Evidence Network in Europe and elsewhere, other programs too, that we all really are looking to be in that yellow box in the top right. We're trusted and we're relevant. But if you're not trusted and you're not seen as relevant, that's okay, concerning, or indeed variations of that in terms of things seen as trusted but with low relevance, not trusted but with some relevance. So all of this is about engendering trust. But trust is actually based on trustworthiness. You have to prove that you can be trusted. It can't be a one-way street that particularly in this case, citizens and patients, wherever internationally, can just be trusting of entities utilizing our data with or without our knowledge. So there needs to be trustworthiness from those entities, full transparency, but also on reliance on fit-for-purpose systems, especially for our distance use. Much of the type of work we're talking about in utilizing data, for instance, for research, is done at arm's length. If we look at these concentric circles and this concentric circle view of governance, many entities are in the outer circles. They're nowhere near the center, the patient, the individual, the citizen. And in fact, that data may even be de-identified, anonymous, or so forth, or not attributable to that individual, and so on. And so that linkage breaks down, and therefore we are even more reliant on systems to be in place and be trustworthy. So these are being addressed, I think, in terms of legislation and policies and programs, but we are still not quite there yet, as we've been hearing, of course, in terms of how to approach governance, and it remains probably one of the largest challenges. Linked to that is public perception. And I would argue that we need to balance perceived risk. So that's not about actual harm. That's much of this we talk about is perceived risk versus societal benefits. I think we need to focus on benefits and mitigate versus actual harm. So manage perceived risk, mitigate against actual harms, have those systems in place as full transparency is mentioned, but actually focus also on the benefits. And actually, in a lot of research, individual data in itself is not useful outside of maybe more rarer diseases. We're really looking at developing cohorts and larger populations and so forth that can help us looking at signals, as it were, biomarkers, outcomes, all those kind of things as well. And actually, we don't really have an interest in identity, but we do need to know that maybe this is the same individual across multiple record systems, for instance. But we have no real interest in the actual identity. And I think we have to look very critically at this balance between perceived risks, harm, and benefits. There's a lot of policy, of course, and here in Europe, a lot of focus on the European health data space, but a potentially transformational legislative response to the need to use data both clinically and also for research across borders and across multiple member states. And it shouldn't be forgotten that we're talking about a European region, at least 27 member states, there's 450 million people. Actually, if you look at the Horizon Europe region, which is one of the largest research funding programs in the world, that covers actually about 43 countries, not only the member states of the European Union, and that's something in the region of 640 million people. This is double the size of the United States, and it's 17 times the size of Canada. And I think that puts in perspective that I think Canada is not necessarily unique, and neither should it be looking at creating necessarily unique responses to these needs of working with data at scale, to supporting clinical care as well as for research. But actually, a lot of systems, policies, and various other things are available internationally. And again, it's not about reinventing the wheel or the world, but it's certainly about taking some of the best bits, as it were, and utilising them within, for instance, the Canadian context. I think that's really important to recognise. But this legislation will be going past European Parliament in ensuing months, and over the coming years, we will see a large-scale regional network being developed to support both clinical care and research, and a Pathfinder project already that's started, or program, should I say, is the European Medicines Agency Darwin program, which is actually creating a regulatory science and technology assessment network across the European region to support accelerated insights generation, evidence generation for regulators and other bodies like HTA. And then vexed issue of interoperability. Well, actually, though we haven't necessarily surmounted all technical challenges, if we look at something like the Eden network, where we're creating a large-scale architecture, currently with 140 data partners in 26 countries, we're using a common data model, in this case OMOP, Observational Medical Outcomes Partnership, from Odyssey, Observational Data Sciences and Informatics Global Collaboration. And all data stays local. It's a federated network, so no data architecture that contains a central database or data lake. Keep the data where it is. It's already protected where it is. It's already got socio-technical governance and so forth as well. But map it to a common data model serially and in parallel across different data partners and different types of data, electronic health records, claims, registries, and so on. But once all in this common architecture, this semantic architecture in the common data model, you can run standardized analytical tools from a central portal to create studies at scale, so network studies of multiple sites, but more importantly also multiple studies. So rather than what we do now, which is curate data on a per query or per study basis, 70 or 80% of our time, actually do a large scale curation with maintenance, but allowing you to conduct studies and asking multiple questions, different questions from the same data source in real time. And this is what we're creating at scale, for instance, within Eden, and clearly would lend itself to similar models across different parts of the world already, and other programs are in the same domain of federated networks like FDA Sentinel, for instance, as well, in the United States, and obviously potential here to work across provinces within Canada. We will be launching aspects of our portal over the coming months, starting with a metadata-driven data partner catalog and feasibility tools to support discoverability of data, and then within this fair kind of approach of findable, accessible, interoperable, and reusable data. So lastly, and I should stop there here in terms of my allotted time, I think one of the challenges we've had to date, and I suspect you all would recognize this in Canada, of course, as well, in other parts of the world, is that we're dealing with an ocean of data, but a desert for analysis. And we clearly got caught with our pants down globally in terms of COVID-19 as a consequence, but actually that's not just in COVID-19, that's in every disease across, unfortunately, the healthcare domain, and for all those that are living with thousands of different diseases where we have very little evidence, both in how best to treat and manage this and what our outcomes are and so on. And of course that impinges, as Barry was saying, on quality of life and health span and so forth as well. And what we're really trying to do is re-green, if you like, this desert to allow us to bring collaborative networks together to work at this at scale, at speed, without impinging on quality, but to ensure that we can actually utilize this ocean of data, potentially in real time or near as, but actually to impact on real world outcomes for people who are being treated and managed for all types of diseases today and not in several tomorrows. Thank you for the time. Sorry for the quick tour de force, and appreciate again being invited to speak. Thank you.
Nigel, thank you very much. That was great. And let me just, before moving on to our third speaker, let me just remind the audience that there is the chat function on the right, and please feel free to put your questions in there, and we will work to come to as many of them after our third speaker has had the opportunity to present. So now I'll turn to our third speaker. A reminder, it is Jillian Oderkirk. And Jillian, I invite you to the virtual stage to present. Welcome.
Thank you very much, Ian. I look forward. I'm glad to be following the previous two speakers, and I'll try to relate to the points that they have made as well. in this intervention. I work, as Ian had said, for the Organization for Economic Cooperation and Development, which is an international organization of 38 member countries, including Canada. And we've been working for over a decade, actually, on this problem of the lack of development, sharing, and use of health data. And we came to working on this problem because health ministers started asking, if we're making such big investments in national health data in particular, why is it that we're not really able to generate indicators of healthcare quality and outcomes that we can compare, so that we can compare with one another and monitor our progress? And in working with countries over this time, we've learned that the barriers that countries are facing are not really on the technical side, as Nigel was indicating. They are much more on the policy side, and this is true definitely in Canada. I mean, what we did at the OECD level is we entered into a collaboration between health ministries and national offices in countries that are responsible for privacy. So these are the privacy regulators, the chief privacy officers, and the individuals that develop the OECD privacy guidelines, from which national privacy legislations have actually evolved across most countries in the world. And together we developed a recommendation on health data governance. And this recommendation asks all countries to implement national health data governance frameworks and sets out some principles to follow when doing that. And these principles address the need to both provide and develop access to data while also protecting the privacy of individuals to whom the data pertain. And this is because the most valuable data in health, as we all know, are personal data. They're data about individuals, their background, their experience of healthcare, and the outcomes that are produced by the healthcare that they receive. And so it's imperative to be able to follow individuals across the cycle of care and to relate care to outcomes. And this is where concerns about privacy have arisen. One thing that we've observed over the past 5 years is that certainly the pandemic has been a catalyst for change, both in improving processes for sharing data, but also for improving the timeliness of data that is available. For example, we now see a large group of OECD countries that have mortality data on a daily basis or in a near real-time basis. When going into the pandemic, there were only a handful of countries that had that capability. So we're seeing a rapid shift in what is occurring. And we've seen, of course, important progress in Canada, as Dr. Goel was mentioning in the opening address to this meeting. However, there's something that's happening in OECD countries that is not happening in Canada. So I just want to take a few minutes to bring this to the attention of the audience. And that's in the reliance of clinical data for monitoring and for research. So when you look at Canada in terms of national health data that's available, and then here we're thinking about the large institutions in Canada, such as the Canadian Institute for Health Information, Statistics Canada, the Public Health Agency, and so on, we see good availability of classical health data that you would need, such as data on hospitalizations or long-term care or mortality, as I had just mentioned. And so in that sense, Canada compares well with other countries. But underneath this, we see a rising tide in the OECD of countries that are not relying on older sources of data, such as administrative systems, claims, insurance data, and are increasingly instead relying on electronic, individual level clinical data. I mean, I can just give you a very short example for why that's important. In an administrative type of data, you might know that a patient has received a prescription, and even for what type of drug they've received, but then you won't know the dosage. So if you want to be able to develop a decision support algorithm to guide clinicians to avoid harmful prescribing practices, or to guide pharmacists, for example, your data is too coarse because you don't know what that dosage was. Same thing with a laboratory test. You don't know what the lab values are. So it's really important, as you're thinking about your national data strategy, that you think about the kinds of data in the 21st century that you really need for your decision support algorithms, for your monitoring, and for research to make progress. And increasingly that data will come from clinical systems. So for example, Canada doesn't have a shared even summary record of clinical data that can be accessed. So that's not only a safety issue for Canadians who move or who travel throughout the country, but it's a huge limitation in understanding major aspects of how the health system is functioning. For example, your national primary health care data only covers 5% of Canadians. It's been very difficult in Canada to develop a database to understand key components of the healthcare system from electronic data. So this is a big part of moving forward, is to address these challenges in data harmonization, in data interoperability, in data sharing and access. And if we think of Boye's comments about transparency and prevention and a feedback loop of information, if you have national data systems that are allowing you to share and exchange clinical data, then you can have national patient portals. And increasingly, OECD countries have patient portals. We've got patient portals now in 16 countries where patients can see their whole record, and also where the government can communicate directly with individuals, both sharing data and sharing information. So we see countries being able to use their patient portals effectively as part of the pandemic response, but there's no such communication ability or access to data for individual Canadians yet. And lastly, I want to mention that Canada's limited by data localization policies, which really restrict the ability for Canadian researchers to work effectively with other researchers around the world in sharing and bringing together health data. And Nigel's point about technological solutions that allow for this, like distributed analytics and federated networks, where researchers can access data but cannot download the data or even need to have access to any of the identifying information, are so important and such a potential solution for Canada. So I would say, as you're developing your national health data strategy, I mean, really look at some of these best practices, whether that's recoding data to a common data model, which the country of Korea is doing right now, or developing data access centers like France has done with the Health Data Hub, or that Finland has done with FinData, or that the Netherlands, you showed a document at the beginning, that the Netherlands wants to do. They want to develop an integrated health data system and to develop a national strategy that allows all the key types of data to be integrated, and to do so in a way that protects the privacy of individuals. So thank you very much.
Jillian, thank you very much. Wonderful to get your perspectives there, and very much appreciate what you've brought to the table. And indeed, appreciate all three speakers, what they've brought to the table. And I invite all three of our panelists to turn on their cameras as we now form a virtual panel to reflect upon what we've heard from each other and the questions coming in from our audience as well. And I would continue to encourage those in the audience to put questions forward, and we'll feed them as time allows to the speakers. To all three speakers, I'll just reiterate my initial appreciation, the richness of your presentations. And as I was listening across them, maybe it's the academic in me. I started to think of various axes, and I was thinking of scale. A people-centered approach I heard a couple of times is so important. But then thinking of moving up to jurisdictional levels, be that regional or national or global. I thought of temporal axes as well, and the ways in which this issue has staging, lifespan, so on and so forth. I then thought of, we're keen at Waterloo on interdisciplinarity, as many are in the world, the social elements, the political elements, the technical elements as well. And then as I see our three colleagues from around the world, the spatial element as well, in the sense of learning across borders. And all three of you have contributed to that richly today. And indeed, the first question, I'm going to prompt you to maybe give us a bit more learning, if you could. As I see our audience, they having seen the participants lists there, they've got different roles in their ecosystems of health data, and many in Waterloo region, but many around the world as well. I guess my first question, panelists, and you can just signal when you want to jump in, is just an opportunity for you to expand upon something you've been talking about, a lesson that you feel you've been learned. Title of our conference is A World-Class Health Data System, and working towards that. And any lesson you would add to the richness of your presentations that you would share with the participants, and give you each, as you wish, 1 or 2 minutes, and then as appropriate, I'll go on to a part 2, or we'll see what the audience has to offer. And I'll just look for a finger wave. Who would like to come in first? And Boye, please, the floor is yours, and then turn to others as they wish.
So we are a part of one approach that we call Movement Health 2030, where one of the part here is saying 80% of the health challenges are more or less the same around the world. Different maturity, different systems, but the challenges are very similar. So just like Jillian and Nigel said, let's learn. It's not plug and play, it's not just copy paste, but let's learn. And these basic challenges that we hear about in Canada, governance, interoperability, portability of data, getting across jurisdictions. Canada is not the only country with these challenges. There are practically no country with these challenges. So let us also together push this and have it as a how can I say, almost stateless approach to let's solve this, because it is very important if we want to improve health.
Wonderful. I might turn to Nigel next, just sort of respecting the order. And Nigel, any lessons you
thank you, Ian. I would definitely echo Boye your comments, of course. And I think, I was really taken from your point about death hospitals, sick hospitals, and then health hospitals, if you want to call it that. I think you call it slightly differently, but that was a phenomenal comment, actually. And we're currently still very much in the sick hospital role and so forth, and how do we deal with disease and so on and so forth, and fair enough. And we're in the 21st century, but we are still talking about 19th and 20th century, if not earlier, problems, right? We still haven't addressed many of these challenges. And though there are some technical challenges, they're not necessarily insurmountable. We've heard this. I would posit that even here in Canada, well, one thing, first and foremost, and it links also to Jillian, your comments, about what we do know is the real world and the outcomes, and how healthcare systems are performing and so forth from an OECD perspective. But every day, and literally in the scope of this hour, in this conference session, there are people who are sick, who are more sick or die because we can't generate the insight to help manage their disease, treat it, chronically cure it maybe in time. That's a travesty, isn't it? That's the real problem in a sick model, at least. We want to move, I think Boye absolutely right, to a health model where we have a very different perspective, but we're not there yet. And in fact, I would suggest that there's only one thing standing in the way of addressing that, and it's political will. we're all citizens. Many of us are patients as well. We're all sick. We all can probably, resonate with what I just said. And it takes the political will to put aside differences like provinces, and I have this system, and my system's not interoperable with your system, or my governance is different to your governance, or my privacy law is prohibitive and yours is too laissez-faire, and so on. It takes real will and therefore guts, but actually to address this, to make the difficult decisions, which are in political, economic, may not even necessarily initially be favourable to your electorate. I think I come originally from the UK, and if you were closing down an NHS hospital, it was, it raised questions in the House of Commons. People even stood for Parliament to stop hospitals being closed. But actually, when you look at it, that's maybe not the best model. Maybe we need more community care, for instance, and so on. So it needs political will. We can talk to the cows come home about all the solutions that we see internationally, and where we can. I quite agree with you, Bo. We can learn from each other, not necessarily just copy and paste. But actually, it takes people with real guts to say we need to make a change. This is no longer tenable. It is completely and utterly inappropriate that citizens of whatever country or region are suffering because we lack insights, and therefore we hold back R&D, we hold back treatment and care because we can't make the right decisions because we just don't know. And look at the start of the pandemic. If I bring it back, because it's a very immediate, example. We didn't know what to do on early parts of the pandemic, even wearing masks, or how best to treat this and so on. Even though, yes, it's a new virus, but many aspects of disease were not new. We see this. We see lung disease in conditions very similarly. And unfortunately, we lost the agenda to a degree because it no longer was a scientifically driven response. It became a politically driven response with all the misinformation, disinformation, and so on. So we have a lot of challenges here, but actually I would really put this in the hands of policymakers and say, look, it takes real guts. We can offer all sorts of solutions, but you're going to have to make this happen with political will. And I think that's what it needs, a kind of revolutionary rather than an evolutionary response if we're really going to make an impact. And I'll stop my my chanting on top of a box.
That's most welcome, Nigel. Thank you very much. Jillian, would you like to come in on this point?
I would, yes, thank you. I think I'd like to sort of maybe even address a little bit. Nigel touched on this earlier, but address the elephant in the room for Canada, which is that Canada is a complicated country. Canada is a federation. Health is a provincial and territorial responsibility. So there are 13 jurisdictions. And so that's why Canada can't have national health data or access to it. And I would say that that's not true. Canada can have the data that it needs and wants with, as Nigel said, the political will to do so. And the best example that I can give is the one that Nigel gave, which is look at what the European Union is able to do. The European Union is not a country. It is an international body with 28 individual countries included within it, and yet it's able to develop all these capabilities that Nigel was mentioning. And just to pick one of them, the European Health Data Space is taking the best learnings from the progress that has been made in Finland, in Denmark, and in France, and essentially saying to all European countries, you can have the same health data space. It is workable within European privacy law, which is arguably stricter than Canadian privacy law. It can be enabled, and you can exchange data, and you can work together, and you can have an exchange of a summary clinical dossier from one country to another. You can be safe when you travel within Europe as a European citizen, and that you will get the best care that's informed on the basis of your health status, no matter what has happened. And that we can grow the research community, and we can do really advanced things, like Nigel was mentioning with the Darwin Project, that will effectively help to code health data to one common data model for Europe for European-wide research, which has the possibility to include Canada, of course, because there's no reason why Canadian data is not coded to a common data model and available, and why Canadian researchers cannot work very closely with European researchers and get the same benefits of that. So, I think it's really unfortunate to continue thinking that Canada has some sort of fundamental reason why it can't move forward. It can move forward. And there are other federated countries that are doing national things with health data, whether that is Italy or whether that is Australia and so on. So you can too. And so that's kind of the main thing. And then the secondary thing I think is really important in thinking about a national data strategy is thinking about not only how you're going to be able to work with provinces and territories to make things harmonized, things like approaches to health data governance and authorizing legislation, for example, things like access to data, distributed analytics that Nigel was mentioning, how you're going to be able to make that national in scope. But I would really encourage Canada to think also about, if you're building data infrastructure, you need stable financing and you need to reward verifiable interoperability. Too often across countries, the financial rewards are given in a way that doesn't incentivize high quality standardized data, and often investments in developing data are short-term projects with no stable long-term financing. And so if you don't think of this as in a holistic way and in a long-term way, then you're unlikely to get this kind of durable data infrastructure that would then completely change Canada's approach to having a health system and encouraging healthy people.
Great, thank you. And thanks for all those responses. We're having some questions come in, which is wonderful. So I'll turn Robin Rowe from the Health Data Research Network Canada, ask a question. You may see it, colleagues, in the chat, as noted about the positives, and asking for you to reflect what sorts of potential harms or risks are being navigated when we think about increasing open data sharing, and a world-class data system. What are some of the big considerations in your space? This just makes me think, in parts of the world that may be ahead of Canada, can you help us understand the future a bit so we better prepare the present? And I might encourage 1 to 2 minute responses for anyone who wants to come in. And Nigel, please, and then
I'll very quickly then. Again, that's what I was reinforcing in my slides, is that we tend to talk about a lot of risks, perceived risks. What's the actual harm? What's the truth here in terms of, I can understand if there's a data breach, there's even down to a psychological issue if it's your data. You're worried about this. What's going to happen with this data? Even if it doesn't say anything untoward about you, but it might be, it might disclose something you don't want to be known publicly. We have a very strange relationship with our personal data, don't we? I can go to my clinic and then say, I don't want my data shared with X party, the pharmaceutical companies, so anybody. And then I can go onto Twitter or Facebook when I get home and talk all about it. So it could be anywhere after that. So we have a very strange relations with that. But I think one of the things is we need a reality check. I mean, actually, I think it's fair to say that quite a lot of security risks currently in terms of data in healthcare are where the attack surface is highest is actually healthcare providers themselves. Hospital data sets and so on is a good example. We see large-scale breaches internationally from these kind of areas. Not so much. We do potentially see this in research and in other venues as well. But actually, there's a lot of clinical data that's potentially either leaked, or you get ransomware now, which increasingly is being seen internationally and so on. So we need to kind of look at different areas where the data is, to understand, where we're actually seeing these actual potential harms, or risks, and then potential harms, and know how to mitigate it. We do have, as Jillian said, lots of legislation now, GDPR and various other things in Europe, California, the acts there, the equivalent in China emerging, and so on. These don't fix everything, and indeed they've created some number of complications. One thing I would definitely argue is whatever legislation you put in, and where we summarily had a problem in Europe was there was legislation and then it was implemented. And what it lacked was an interpretation layer in the middle that took the legislation and then provided guidance on how you operationalize it in terms of your practice and your institutions and so on. And not everyone's a privacy lawyer. So we've run into difficulties. And of course, GDPR lost the ability in going through the Parliament to have one approach. So all member states were allowed to evaluate this. And so we've ended up with 27 different interpretations of GDPR. So it's not all perfect. It's getting there in increments, but there are challenges. And very, very quickly last, European Health Data Space, in case I don't get a chance to say that later, I shouldn't probably say this, but it's widely available, but there's a draft leaked version of the European Health Data Space. Here we are in our modern world on the web. If you just, in your favorite search engine, search for leaked European Health Data Space, Politico and various others have already leaked it, but it's all over the web. So if you haven't seen it, it's worth a read. It's not there yet. It's a draft, but it's very, very interesting. And I'll stop there. Sorry.
I better say no comment in response to the last one. And smiling, Boya, would you like to come in on this?
Yeah, so I think there are several things to take in. So I fully agree with what Jillian also was saying. There's no reason to think just because you're a federated state you can do these things. But it's also, I mean, you should also learn from Canada. Doesn't have the same legacy challenges that, for instance, Northern Europe has. So you can start a bit from the fresh or from the scratch in it. So it's very important to learn, but not necessarily to copy. Right, and we all agree on that we have too many silos, but the future is a combination of hyper specialization and holistic thinking at the same time. So it's building bridges between silos. It's not breaking down silos. We still need the expertise. It's very, very important and that's where we don't have leadership training. We haven't. I mean, we are all trained reductionistically, so it's a challenge. We should admit that challenge. And I fully agree with Nigel on perceived risk. So why do we produce data? It is actually to de-risk life of persons. We want to use knowledge to help persons to a better life. So if we produce the data to put them into Fort Knox, why do we produce it? It doesn't make any sense. So this is a philosophical question. It's a political will question, but it's also a societal question to say, if we want state-of-the-art healthcare, I don't really think that the state-of-the-art digital healthcare is the right question. The right question is, do we want state-of-the-art health, where care also is a part of it? Then you will get it, but it needs to be the outcome.
Thank you. And Jillian, would you like to come in briefly on this?
Yes, thank you, Ian. I'd just like to come back to some of the points from the other panelists earlier. It's thinking about the harm we are doing by not sharing and utilizing these data. It's I don't know how to say this. I encourage Canada to create a vision board, to create the vision of the kind of health and healthcare you could really have, and the kind of health research and knowledge and innovation for people you could have if you could provide privacy protective access and development of data and really see it as a resource. This doesn't mean that there are no risks to having health data, but I would say, I think arguably the large data handling institutions that Canada already has are world leading and world class in their protection of the data that is in their custody. I mean, where you see data custody failures, which needs to be addressed, is at the healthcare provider level, unfortunately. And that is understandable, because healthcare providers' primary responsibility is not data protection, it's provision of care. But they end up with quite a bit of data to look after without perhaps having adequate preparation and training and support for what they need to do. So that must be addressed. data security throughout the world is challenged by the progress of attacks on data. So Canada, as a member of the international community, will have to work more and bring more to the table in the area of cybersecurity. But that doesn't mean that we want to all roll back and live in the 1980s or something again. We don't. We want to bank online. We want e-commerce. We want our smartphones. And we also want what we've never had, which is 21st century health and care. We are like the last major sector, economic sector, to participate in the digital transformation. And we need to vision what it is that we could be having and understand the harm of not having it.
Yeah.
Thank you, Jillian, for that. I'm going out on a limb as a moderator. As we see, we only have a couple of minutes left and wonderful questions before us. I'm going to challenge our panelists to come in and Jillian, then Nigel, then Jillian, choose a topic. Jose asked us about technology, flagged blockchain, if that triggers anything. Ewan asked us about the data literacy of our leadership and the importance of that. And then in moderator school, they taught me, give the panelists an opportunity to say anything they want at the end. So in the spirit of, we've only got a few minutes left, in the spirit of, I think I'm talking to a number of European-based people, and Canada just qualified for the World Cup. After a minute, you'll get a red card. So I'll ask you to kindly wrap up. So a minute to touch on whatever you wish. Boya, the floor is yours.
So I do think that ledgers and blockchains in different way is going to be a part of the solution. It's not going to be the whole solution. The first generation blockchain in itself has many flaws, which makes it very, very difficult. But I worked in Canada. I know the capacity is there. I know that the will infraction is there. So it's more about getting these things together and really, I mean, you can't solve it alone. But I would also say that there is a bigger ask for Canada. Canada is very proud of hosting more or less the whole world on Canadian soil and can also work towards the whole world. This is the 1090, and COVID has shown us that. We are only focusing on the richest 10% when we do this solution. Let's focus on the other 90% as well. Make that a part of your raison d'être. Push it and let Canada lead.
Wonderful. Thank you very much for that. Nigel, the floor is yours for a moment.
Thank you. I need to be short for a change. So I'll just pick up that point on literacy. I think that's an excellent point. And actually, they say charity begins at home is an oft-used phrase, but maybe we should say literacy begins at home, because even inclusive of security, we all as individuals should have more understanding and interest in our own data and where it's used, not just in healthcare, but across the. I mean, for me, I'm not on any social networks. That's a personal decision, but I don't trust them. Sorry, so I won't use them. No LinkedIn, no Facebook, no Twitter, no nothing like that. So I am on other things as well. You can't avoid it today's world. And I think Jillian mentioned the smartphone. We make a trade-off every time we use our devices for convenience versus trust. And we need to do that in a more informed way. So it starts at home. We need to ensure that we are given the tools to do it, but we need actually as a society to understand that we live in an increasingly digital society, and that we as individuals, ourselves, whether it's ourselves or policymakers, whoever, actually there needs to be a commitment as a society to how we manage this. Because healthcare, yes, it's one of the last sectors, red card coming, but we also need to look at this across society. Healthcare is part of society. It's not a silo in itself. I'll stop there.
Wonderful,
Thank
Nigel.
you for the red card, Ian.
You may continue on the pitch. Nigel, thank you very much. Jillian, I'll pass it over to you for a moment.
Thanks, Ian. I guess I would just say what I failed to say at the very beginning, which is congratulations to Canada on starting the development of a national health data strategy and having these kinds of conversations and bringing in expertise from other countries to inform the best possible reform and strategy. So I would just say this is great. This is absolutely needed. And even though it may be coming a little bit late compared with other countries, this gives you a fantastic opportunity to learn from previous experiences that have already occurred and to take the wisest possible action in response to that. And I think the technology has really caught up to Canada. I really do see the kind of federated network common health data model that Nigel was talking about as being so useful for Canada, and something that provinces and territories would like, because they don't have to necessarily let go of their holding of the health data and their primary custodial responsibilities for it. So there's all kinds of technical possibilities now that weren't around 5 years ago. So, I just encourage you to keep going.
Wonderful. Jillian, thank you very much. And the richness of the remarks from all three of you, boy, Nigel and Jillian, I think the audience would be happy to join me now in thanking you very much. And you're getting one live applause here and many virtual claps as well. Thank you to our three panelists for joining us. To all of the participants, thank you very much for attending this session. Thank you for your contributions. We'll be taking just under a 10-minute break now, and the conference will be reconvening at 2:40 local time here in Waterloo. Once again, thank you very much and enjoy the rest of your day.